Okay, so good morning and thank you for the opportunity to participate in the American Heart Association joint session with the Brazilian Society of Cardiology. My name is Ricardo Kuniyoshi from Central Core and Vitória Parte Hospital in Brazil. And my topic today is exercise and sport in patients with non-arrhythmias. Is it possible? I have no disclosure to declare. Well, we just know that regular exercise reduces the risk of adverse health outcomes. In fact, cohort studies show that those affect relationship between the exercise level and the reduction of cardiovascular and all-cause mortality. And because of these findings, current guidelines recommend a moderate aerobic exercise for at least 150 minutes per week. However, the problem is that we have seen at the media many cases of sudden death during exercise in athletes, and of course, with far-reaching impact. This is a Brazilian soccer player that had a sudden cardiac arrest during a soccer match in 2004. He was 30 years old, had hypertrophic cardiomyopathy, and unfortunately, he died in this event. It's important to emphasize that despite the huge media exposure of sudden death in athletes, its incidence is actually very low, not only in young competitive athletes, but also in non-athletes, as you can see here in this recent study from Spain. About the mechanisms of sudden death, Dr. Baez de Luna showed us that the vast majority of cases occurs during a malignant ventricular tachyarrhythmias. So the typical sequence of electrical events is a ventricular tachycardia that degenerates to ventricular fibrillation, ended up in sudden death. Although physical activity can create a favorable environment for arrhythmias, in particular ventricular arrhythmias, the presence of a structural or electrical cardiac anomaly is an important component for the occurrence of sudden death during exercise. So the identification of individuals with high-risk underlying cardiac anomalies, either structural or electrical, is crucial to avoid sudden death during sports practice. This concept was well demonstrated by Dr. Corrado when they showed a significant reduction by 89% of annual incidence of sudden death in athletes after beginning the identification of individuals with heart disease before the participation of sports. So if you have a patient with arrhythmia who wants to engage in physical activity, we need to investigate the presence of an underlying heart disease and complex arrhythmias. If so, the next step will be further investigation to stratify the risk of sudden death. High-risk patients won't be allowed to do sports activity until treatment and prevention of sudden death. On the other hand, patients with a low risk and people with no heart disease and less complex arrhythmias would be allowed to engage in any physical activity or sport. But of course, these patients will be treated and monitored if necessary. However, in some cases, we are not so sure about the risk of sudden death during exercise. And this includes patients after adequate treatment of high-risk arrhythmias. In this situation, the best way could be adopting a shared decision-making approach. And in this strategy, it's worth mentioning that the final medical decision should not only be done by the cardiologist or even electrophysiologists, but also performed by physicians with a large experience in sports medicine. And in case of competitive athletes, the official team physician as well. Besides, of course, the participation of all other stakeholders involved. In this sense, Dr. Lampert has a clear point of view of shared decision-making approach. And I think not only patients with ICD, but also every high-risk patient should be warned about what the risks are, what data we have right now, what the data are lacking. And in many cases, we need to say that there is no zero risk in this decision. Now, let's talk about some specific situation in cardiac arrhythmias and exercise. Supraventricular arrhythmias without underlying heart disease are usually a benign entity, except for the Wolff-Parkinson-White syndrome. In this situation, the presence of an accessory pathway with an anterograde factor period up to 250 milliseconds denotes high risk of sudden death, and cath ablation will be the best option for this patient. Atrial fibrillation is another important and common supraventricular sustained tachycardia. AFib does not increase the risk of sudden death during exercise, then can bother the athletes because this arrhythmia can reduce exercise performance. In this situation, cath ablation could be a good option to treat these patients, as we can see in some studies that show the similar results in both athletes and non-athletes. And what about ventricular arrhythmias? Premature ventricular contractions are another common arrhythmias, either in the general population or in athletes. Individuals with ventricular arrhythmias like PVCs, non-sustained and sustained ventricular tachycardia without structural or electrical heart disease have low risk of sudden death, but in some cases, the PVCs can result in disabling symptoms and can decrease exercise performance as well. This is another important point. Patients with high burden of PVCs should remain under surveillance over time. Once these patients can develop myocardial dysfunction, this is so-called arrhythmia-induced cardiomyopathy that generally occurs in patients with about 10,000 PVCs in 24 hours, and the cath ablation could be a good option for those patients. Well, as we said, the presence of ventricular arrhythmias may be a clinical manifestation of a structural or electrical heart disease like arrhythmogenic ventricular cardiomyopathy or a CPVT that is usually manifested by bidirectional ventricular tachycardia during exercise, and it's an electrical heart disease with high risks for sudden cardiac death during physical activity. So the presence of complex arrhythmias, even in asymptomatic patients, is a red flag that we need further investigation of subtle structural or electrical heart disease. This is a very challenging situation for us that can occur in patients without the structural cardiac abnormality. Fortunately, very rare. The PVC that trigger ventricular fibrillation. In this context, the presence of short coupled interval could raise a red flag, but not in all cases, because particularly in PVCs arising from right ventricular outflow tract that trigger ventricular fibrillation could have a long coupled interval. That is a PVC away from the T wave. And we have our own challenging case that I want to share. It's about a 56-year-old man with apparently benign idiopathic right ventricular outflow tract PVC with long coupled interval, but that triggered non-sustained polymorphic ventricular tachycardia and ventricular fibrillation. After cath ablation that eliminated the PVCs in outflow tract of right ventricle, he no longer had recurrence of malignant ventricular arrhythmias since 2017. In some clinical situations, a continuous vigorous exercise can be harmful to the heart. It's because high-level exercises can accelerate a clinical manifestation of heart disease. It's the case of individuals with a genotype positive but phenotype negative of ARVC. In these situations, vigorous exercise overloads the right ventricle and can accelerate the phenotype of this cardiomyopathy. Regarding brain arrhythmias, if you have, of course, a clinical situation with clear indication for pacemaker therapy, this patient will not be cleared to physical activity until adequate treatment. So in patient with pacemaker, the clearance for sports will depend on the presence of an underlying structural heart disease, the risk of damaging the device, and the level of pacemaker dependence. Some sports like soccer, basketball, and baseball may be possible while wearing appropriate padding to protect the pacemaker. Athletes who are completely pacemaker dependent should not engage in sports in which there is high risk of damage to the device, or in sports with high risk in case of syncope. In patients with ICD, regular moderate exercise exerts a protective effect for those patients, but besides the same precautions adopted in people with pacemakers, we need to consider that there is little data about the efficacy of ICD under extreme conditions of exercise and mental stress that are really common in some sports, particularly in competitive ones. So the best way in this situation could be a shared decision-making approach. So in conclusion, I could say that the health benefits of regular exercise are well established. The incidence of sudden cardiac arrest, cardiac death related to sport or exercise is very low, although its occurrence is a matter of significant social and media attention. The presence of cardiac arrhythmias does not per se increase the risk of sudden death, but can be a clinical manifestation of a high-risk heart disease. In clinical scenarios that you don't have enough data to ensure the safety in releasing patients to exercise, the shared decision-making approach is a reasonable way to deal with it. And finally, regarding the initial question, is exercise in sports in patients with non-arrhythmias possible? I would say yes, in the majority of cases. Thank you very much for your attention.